we're going to talk about 4 very interesting cases which presented not typically. And you know that hypertension presentation in children is often vague. So they presented in different manner. And then at the end, we found very interesting diagnosis. So this is the whole spectrum. So when we talk about hypertension or blood pressure regulation, there are 2 major factors which are there. One, of course, is how much is the cardiac output and how much is the peripheral vascular resistance. So these are the 2 major determinants, and many of the endocrine factors will play a role in that perspective. So we know that calcium is a major stimulant as far as the vascular constriction is concerned, and that is why calcium channel blockers are used for management of hypertension. We know that the fluid is largely regulated by multiple endocrine systems. And important factors, of course, are the sodium and the growth hormone. Both play an important role in the fluid regulation per se. Then cardiac contractility and the heart rate is determined largely via the thyroid function. So there are multiple endocrine organs beyond the adrenals which are also involved in the whole perspective. Coming on to the most important part, of course, is the renin, angiotensin, aldosterone system, in which renin basically converts the angiotensin, and then we have the ACE converting into angiotensin 2, which triggers the adrenal production of aldosterone, which is a primary regulator of sodium absorption in the body. Now, adrenals also produce cortisol, which are the trigger as far as catecholamine production. So overall blood pressure regulation involves a number of hormones, and disorders there could cause what we can say, quote unquote, endocrine hypertension. So we all are aware about thyrotoxicosis, increased renin state, which can cause that, hyperaldosteronism, which can be primary or secondary, Cushing syndrome or cortisol excess, excessive catecholamine production like pheochromocytoma, of course, will cause that. And we also know that hypercalcemia and hyperparathyroidism and growth hormone excess can also cause this. So a large number of endocrine disorders are important factors as far as hypertension is concerned. Most of them, be it thyrotoxicosis, be it hypercalcemia, be it growth hormone excess, the symptoms will be clear. The symptoms may actually be quite vague for a aldosterone producing tumor, and this is what we're going to focus more in terms of what we can say, quote unquote, increased aldosterone effect. So either the aldosterone is more, or there is another molecule which is behaving like aldosterone acting on the receptor, or the receptor itself is hyperactive. So that becomes important. So when we talk about increased aldosterone effect, the situation can start right from the production of renin. So you can have scenarios in which there is increased renin production. The classical example we all know is a renal artery stenosis, in which the kidneys feel that there is no blood flow and they are going to push a lot of renin to increase the perfusion, causing hypertension. There could be issues at the level of adrenals, which are producing more aldosterone. And this production can be because of an isolated adrenal adenoma, adrenal hyperplasia, or what we call as a glucocorticoid remediable aldosteronism, which is basically a splicing defect in which the regulation of aldosterone secretion happens via ACTH, and that is going to control that. We can, of course, have a problem in the 11 beta HSD2, which basically shields the mineralocorticoid responsive tissue from the impact of cortisol. So if there is a 11 beta HSD deficiency, like apparent mineralocorticoid excess, you can have a scenario. And similarly, of course, in Cushing's, you have got so much level of cortisol, particularly if it's an ectopic form, which is there. In those scenarios, you may have hypertension, hypokalemic alkalosis, which will happen. So that is actually a apparent mineralocorticoid excess scenario. You can also have increased activation of the epithelial sodium chloride channel, and this also is going to trigger increased activity. The classical example is Liddle syndrome, in which the epithelial sodium chloride channel is more working. You are absorbing more sodium, causing hypertension in that regards. As I said, you can also have aldosterone-like molecule, which have got mineralocorticoid activity. The classical example is DOC, which may be produced in the setting of CAH variants like 11-hydroxylase and 17-hydroxylase. 11-hydroxylase will classically present with XX-DSD and precocious puberty in boys. 17-hydroxylase will present more with XY-DSD and delayed puberty in girls. So these are the overall gamut of scenarios which may be causing an increased aldosterone effect. The problems could be because of a true increase in aldosterone, which would basically be either an adenoma or a hyperplasia. There could be a familial cause like glucocorticoid remediable aldosteronism, which I said is because of the regulation of aldosterone production via ACTH. So it's an unusual production regulation via ACTH. Then you can have a DOC excess because of a tumor or 11 or 17 hydroxylase deficiency. And then finally, you may have no increase in aldosterone, but there is an apparent excess because there is decreased conversion of cortisol to cortisone, resulting in apparent mineralocorticoid excess or a Liddle syndrome. So we'll be discussing about probably 5 to 6 cases if we get time, but there are 4 key cases which will focus about pretty much starting right from adenoma to 17 hydroxylase deficiency to 11 beta HSD deficiency and a level higher also about renal artery stenosis. So we'll talk about a lot of these constellations approaches from that perspective. All of you can go and have a look at our website, learning.gosociety.in, which has got a lot of free resources as well as courses and fellowship programs and diploma in endocrinology, which are available. We do run around 3 programs a month with regards to the journal club, the postgraduate lecture series, and the grand rounds covering these aspects. There are publications which are available both online as well as hard copies and mobile application which can be used for access and point of care. So what we'll do today is to focus about 4 cases after we have the basic understanding of approach so that it becomes easier. So we'll talk about a case of high renin, then adrenal mass, recurrent stroke, and hypertension with nephrocalcinosis. These are 4 very interesting cases. If we get time, we'll talk a bit about 11 hydroxylase and 17 also as case vignettes in that regards. So now in this background of the overall approach for these causes, the questions are, is it really an increased aldosterone effect? If it is an increased aldosterone effect, is it because of an aldosterone excess or an apparent excess? And finally, what is the cause? So as we have discussed that hypertension is particularly common in older individuals. But if you have a young individual and there is a hypertension, we are always worried about that. So if there is an onset of hypertension before 20 years of age, and in children, we know that first you have to exclude all the renal parenchymal and the renovascular causes. Once you have done that, you can think of pheochromocytoma, you can think of coarctation of aorta, then you're talking about an endocrine cause or a low renin cause of hypertension. However, it has now been identified that around 5% of what we call quote unquote essential hypertension in adults is actually because of aldosterone excess. So if you have onset after 20 years also, but requiring 3 or more medications, you have to worry about that this could be a secondary hypertension and do a basic screening for the aldosterone excess in that regards. Now, within a group of individuals who have hypertension, if they have frequent muscle cramps, which basically would mean hypokalemia or hypomagnesemia, if they have features of polyuria and failure to thrive, strong family history, particularly for the autosomal dominant variant, which is the glucocorticoid remediable aldosteronism, and as I said, polyuria and hypokalemic alkalosis, you are thinking more in terms of endocrine hypertension. Now, one concept often people have that everybody who has got a hypokalemia, we are going to think about aldosterone excess. So if the potassium is normal, the chance of aldosterone excess is less. This is untrue. A large number of patients who actually have endocrine hypertension may have normal potassium. And this is an important message to consider, that you have to consider even if the potassium is normal. If the potassium is low, you definitely have to worry, but normal potassium does not exclude the possibility of this group of disorders in that perspective, and that becomes important from that regards. Now, how do we, once we have decided that this is possibly a renin-angiotensin effect, how do you assess the scenarios from there? So essentially, we have already discussed that we have got angiotensinogen, which is converted via renin to angiotensin 1, which is converted via the angiotensin converting enzyme to angiotensin 2, which actually is a very, very important agent as far as fluid regulation is concerned. Angiotensin 2 causes vasoconstriction, increasing blood pressure. It increases aldosterone secretion. It increases thirst. So it has got multiple mechanisms by which it is acting to increase the fluid status overall from that perspective. And this aldosterone will then cause action on the mineralocorticoid receptor to assess. So if we talk about the renin-angiotensin-aldosterone system, the assessment can be done at the level of actual measurement of renin, which is a direct renin assessment, or a plasma renin activity. Now, direct renin is basically an immunoassay. Plasma renin activity is actually a bioassay. So we need to be careful when we differentiate. We'll talk a bit about how they are different and which is preferable in that regards. We, of course, have to measure aldosterone in combination with renin, like we say FT4 TSH, ACTH cortisol, insulin glucose, calcium PTH. Same is that aldo has to be combined with renin to get any meaningful result in that perspective. So the screening investigation essentially for anybody whom you're thinking of endocrine hypertension is an aldosterone along with renin level. Now, what you need to be cautious about that this should be done ideally in the morning around 8 a.m., 2 hours after the patient has waken up. Very importantly, 5 to 15 minutes of sitting posture is important. And because if you're doing particularly a plasma renin activity, which is a bioassay, you should use a pre-chilled tube. Otherwise, you will have a falsely declined level as far as the renin is concerned. Now, we all know that there are two types of assays available. One is the renin and other is the direct renin content. So plasma renin activity is basically a bioassay, and direct renin is essentially a form of an immunoassay in which you are measuring the renin content in that perspective. Now, very importantly, the renin activity will depend upon angiotensinogen, how much angiotensinogen is available there, and it is not affected via estrogen. So the major differences is if you talk about cyclical variation, you will have much more variation which happens in direct renin content as against a plasma renin activity. So during ovulation, if you want to look at PRA will be a much better strategy rather than a direct renin content from that perspective. Moreover, the assays are more robust for plasma renin activity. So most of us will go for plasma renin rather than a direct content. But if you are going with either of them, remember the ratios will be different. The aldosterone to renin ratio will be different and your interpretation will vary also from that perspective. So this is something important to identify what your lab is doing and how do you want to assay from that perspective. Very importantly, if somebody is restricting salt, or in a standing state, you will have an elevation of renin. Levels are typically highest in morning, and renal failure, of course, is a scenario where your renin will be less because it is being produced by the kidneys also in that perspective. Now, another very important problem which happens in these scenarios is that many of these patients are already on many medications. So what is the impact of those medications when you are assessing the aldosterone-renin ratio? Because otherwise, you will get a false positive or a false negative result in that perspective. So if you have intake of spironolactone, essentially we're talking about calcium channel blockers, ACE inhibitors, ARB and spironolactone, all of them will suppress in a way aldosterone activity. So that will falsely give renin levels which will be high. So you will miss primary hyperaldosteronism. On the other hand, if your renin is still low, in somebody who is on ACE inhibitor, on ARB or spironolactone, you are 100% sure that this is a low renin or an endocrine pattern of hypertension. If somebody is on sympathetolytic agents, if you are beta blockers, central agents like clonidine, methyl dopa, these are all going to inhibit the central sympathetic trigger. So therefore, you will have a low level of renin, and because renin goes low, your aldosterone to renin ratio will go up. And you will falsely label somebody, okay, he does not have primary hyperaldosteronism, but you will say this is primary hyperaldosteronism. So these drugs should be avoided in that perspective. Direct renin inhibitor is not very commonly used now. That also causes a confusing scenario in which your PRA is less because you are antagonizing renin. So your bioactivity is less, but your immunoactivity is normal, because your renin content will be normal, but this is something which is not really commonly used in that perspective. So what do? We shift them to drugs which do not affect these ratios, which could pretty much be an alpha blocker like prazosin or a calcium channel blocker like verapamil, which can be there. So prazosin is a good drug to start off in that perspective. Now, very importantly, if somebody is on spironolactone, somebody is on ACE inhibitor, somebody who is on ARB, you expect them to develop hyperkalemia. If they are hypokalemic, then that is something that this is actually overriding the effect. This is 100% sure that this is an endocrine form of hypertension or renin excess, which is there in that perspective. Now, when you're assessing the RAS system, you need to remember that like FT4 and TSH, like calcium and PTH, like glucose and insulin, there is a log linear relationship between aldosterone and renin activity. If your aldosterone level goes up, renin should be zero. So you have to basically correlate between aldosterone and renin, and they have to be done parallelly in that perspective. So if aldosterone is high, PRA level should ideally be low in that perspective. This is primary hyperaldosteronism. If, however, your PRA is high, it means renin is driving the whole picture. And this would mean something like a renal artery stenosis sort of a scenario. Now, how do you interpret this? So what I'm doing now is to use PRA, plasma renin activity, which is more commonly used. And I would prefer that because it's a better bioassay. And the ratio between aldosterone and plasma renin activity, which is ARR, or plasma aldosterone to plasma renin ratio. If aldo is more than 10 and renin is undetectable. So theoretically, whenever we say your FT4 is high, TSH should be 0. If your aldo is high, your renin should be 0. This is classically primary hyperaldosteronism. You don't need to worry about this in a great extent. However, if the renin is high and the aldosterone to renin ratio is less than 10, this suggests a hyperrenemic state. And we'll talk about both scenarios. If both of them are low, this means that there is some other form of mineralocorticoid which is acting, which could be a DOC, or there is an apparent mineralocorticoid excess, or Liddle syndrome. These are the possibilities which will be there from that regards. So now if we compare the common etiology in the form of renal artery stenosis, adrenal adenoma, hyperplasia, these are pretty similar. GRA, these three will be similar. CAH variants, AME and Liddle, renin level will be low in everybody except a renal artery stenosis. So in this scenario, your renin is high because that is driving the overall picture. If we talk now about the aldosterone level, the levels will be high in everybody except for apparent mineralocorticoid excess, Liddle syndrome, and CAH variant. So if you have low renin, low aldo, you're talking about either DOC or you're talking about 11 beta HSD or Liddle syndrome. And finally, if you have renal artery stenosis, CT angio will give you a clue. For adrenal adenoma, hyperplasia, CT becomes important. For CAH variants, as we'll discuss, there would be the option of doing the specific metabolites. For AME and Liddle, you can use the impact of spironolactone. Now, if somebody is responding to spironolactone, it suggests an apparent mineralocorticoid excess. If they are not responding, this suggests a Liddle syndrome. And now, of course, genetic diagnosis can also give you the precise diagnosis in the form of a clinical exome sequencing, which you can do. So the approach to an individual who presents to us with suspected endocrine hypertension is to look at the renin level. If the renin level is high, possibility is renal artery stenosis, go for a CT angio. If the renin level is low, go for DOC level. If DOC is high, this is 11 or 17 hydroxylase deficiency, go for a tumor, go for CT and genetics. If you have got low DOC and your aldosterone is high, this is primary hyperaldosteronism. So low renin, high aldo, then you go for CT, and then young patient, family history of recurrent strokes, think of a GRA. So response to steroid will be significant. If you have got a low renin, low DOC, low aldosterone, this is either two differentials. You're thinking of either an apparent mineralocorticoid excess or a Liddle syndrome. Look for spironolactone response. If it's there, it's most likely a 11 beta HSD2 defect, which is apparent mineralocorticoid excess. In this case, you can do a genetic study. And if you have got no response, this is most likely a Liddle syndrome and you have to go for a genetic study. So basically, go for a combination of renin and aldosterone. These two will give you a clue. DOC will also be helpful, and then spironolactone response. High renin, renal artery stenosis, low renin, high DOC. You got specific diagnosis, but you will get clues. If there is a XX DSD, think 11. If it's a XY DSD, think of a 17. If, however, these are not there and your LDO is high, look for an adrenal tumor. If your LDO is low, look for spironolactone response and you will get the diagnosis.
Every fourth adult in this new era has a hypertension. And the most common cause are essential or the essential hypertension due to the obesity or diabetes or any other causes. While endocrine cause of the hypertension constitute 50% of the causes. Among them, Cushing syndrome, thyrotoxicosis, growth hormone excess, which cause the major cause of the endocrine hypertension. So among the 15 causes of the endocrine hypertension, we have to, if these causes are not there, then we have to think about the adrenal causes of the hypertension. So today we are discussing about the case that we found in the in our OPD, which presented us as an adrenal insulinoloma, and which at every point it was a twisting point, and finally diagnosis came out as a some another cause. So if I start my case, then we a 57-year-old lady with the type 2 diabetes with the hypertension, who has a complaint of the left side of abdominal pain and was on 3 group of the medication for the hypertension management. And there was a typical history that she has a fluctuating type of BP. There was a history of palpitation, headache, hypertension, and fluctuation of the BP. So BP here was not sustainably high, but it was fluctuating. And basically, this case was referred to us at the endocrine unit for the adrenal insulinoloma and the planning for the surgery. At our point of time, the patient, the weight was 65 kg, so patient was not that obese. BP was 130-165 mmHg at the first presentation. Creatinine, HB, and SGPT was normal, which was ruling out any systemic illnesses like chronic renal failure or another pathology. Here, I want to highlight about the electrolyte imbalance. Here, the sodium was 134 and potassium was 3.09 millimole, which was suggestive of the hypokalemia.
Was she on thiazide at any point?
Yes. That time she was on the high side, so it was explaining this hypokalemia. So here sodium is 134, which is hyponatremia, and potassium is also at lower side. So this is the patient was on the high side, which was explaining this electrolyte imbalance.
So I think this is again a big message that normally we say if somebody is on thiazide, there is hypokalemia, we say thiazide induced. But you need to keep your eyes and ears open. So if you have spontaneous or thiazide induced hypokalemia, still you have to keep your possibility of a primary aldosteronism on the higher side.
Yeah. So, and treating physician has done plasma metanephrine level that was high, which was 559 microgram per 24 hour, and the normal level is 24 to 95 microgram per 24. So as you are seeing, it is sky high level. So the question is that is it pheochromocytoma? So, and the CT was suggestive of there was a well-defined mass in the left adrenal gland, measuring around 20 multiply 14 multiply 18 mm in size, which is regular in margin, and there was no any microcalcification. So, by seeing the CT scan, there was no any microcalcification and regular margin with a lesion less than 4 centimeter was ruling out adrenal carcinoma or malignancy. So here
vascular blood flow was more. So that was again suggested that there is increased blood flow, probably producing some functionality of the particular tumor was addressed at that point of time. So she was actually referred to me primarily as a adrenal insulinoloma. These all things like hypokalemia, hypertension, free drugs, they were not given importance. And a high level of plasma metanephrine. Now, what is the specificity of plasma metanephrine?
Sir, specificity for the diagnosis of the pheochromocytoma is a very less. We have to do urinary metanephrine or urinary metanephrine level.
This is a very, very important message. That if you are doing a screening test, so for incidentaloma, you don't have a very high pretest probability of pheochromocytoma. In that scenario, using a plasma metanephrine will be inappropriate to go for that. If you had a family history and you know that there is a gene which is involved, then doing a plasma would have been better. So that was an erroneous choice from the treating physician. But I think at least they were able to pick up the incidentaloma and refer to us for evaluation. So what went at that time?
So the diagnosis was put at time by the treating physician as a patient may have adrenal incidentaloma with a query left adrenal pheochromocytoma was made by treating physician, and after this initial investigation they have referred to us. So now story has started from our clinic. So before labeling to anything, we have to go through the 3 or 4 question that is it adrenal incidentaloma. So what is the adrenal incidentaloma? If lesion is less than 2 centimeter, and if it is detected on the routine investigation without any clinical symptoms, that fits into the criteria of the adrenal incidentaloma. More than one. More than. Here our patient has a lesion more than 1 centimeter, which is 2 centimeter, and there was no any clinical picture and was incidentally finding. So it was fitting into this category. Now answering to those questions, we have to encounter with the other question that if it is an incidental lesion, there is it malignant or hormonal excess. If it is benign lesion, then we don't have to worry unless and until it is more than 4 centimeter. But if it is less than 4 centimeter, if it is malignant and the benign hormonal excess, then we have to treat this cause immediately. So by seeing the flow chart of the adrenal incidentaloma, so there are 4 different categories. Here the lesion was unilateral. So all the causes of the bilateral incidentaloma was ruled out. Here, it was not suggestive of the malignancy as the CT finding and patient has no any virilization. So malignant causes also ruled out, and their CT was not suggestive of any myeloid tissue or nodular tissue. So there was apparently we left with the 4DD, with the, could be the benign lesion, could be the adenoma, pheochromocytoma, carcinoma, query Cushing syndrome, or aldosterone producing tumor. So now, after that, we have advised some investigation. As in investigation, serum cortisol level was high, which was 510 nanomole per liter, and after the dexamethasone suppression test, it became very low. And as sir has told, urinary metanephrine level and metanephrine and non-metanephrine level was quite normal here. And
another important thing to remember is that what is the cutoff for overnight dexamethasone suppression test in an incidentaloma?
Yes. So here I want to highlight the cutoff for the adrenal incidentaloma. Generally, we put the we keep the cutoff of 50 millimole nanomole per liter for the normal Cushing syndrome, but for the increasing the specificity for the incidentaloma, we have to keep the cutoff higher, 138 nanomole per liter.
So the original cutoff is used because if you are just using a cutoff of 50, you will be detecting many of the subclinical cases. Then you have a tumor and you say it's subclinical Cushing, you have to go for surgery. So then everybody, a lot of people will go for surgery. That is why the cutoff is actually raised. And that is why urinary free cortisol is not used for screening. So a very specific thing to remember is in adrenal incidentaloma, it is the overnight dexamethasone suppression test, which you should be looking at with a higher cutoff. Around 140 will be the higher cutoff which we'll be using in that perspective.
Okay. So here, as we are seeing, there was a cortisol excess was not there, and the screening urine metanephrine and non-metanephrine level was normal. And again, for confirming, we did the urine adrenaline and noradrenaline level, which was again came to normal, which was ruling out pheochromocytoma and the carcinoma query Cushing syndrome. So now we have left with the 2DD, which is the adenoma and the aldosteronoma. So before jumping towards the investigation, we have to ask some basic question before the diagnosis. Because there are the series of tests for the diagnosis of the aldosteronoma. So clinically we have to rule out. So coming to my basic question, that is it the pathological hypertension or essential hypertension? So what are the definition of the pathological hypertension? If it is hypertension and hypokalemia, if it is treatment failure resistance hypertension which is not controlled over more than 3 drugs, if it is finding on the adrenal incidentaloma, and if it is in younger age, and if it is severe hypertension more than 160 per 100 mm per hg. So
essentially early onset refractory require and which has got severe form. These will be the scenario which is there. Plus, you have mentioned incidentaloma. So, with incidentaloma, if you have hypertension, you cannot say that this is more like an essential. You have to start working that this may be aldosterone excessive. So, that is an issue. So, if you have functional evaluation, if there is hypertension with incidentaloma, you would also look for aldosterone and PRP, which was not done in the initial.
Okay. Yeah. So here a patient has a drug history that patient was on 3 drugs, which among them 2 were the ARB inhibitor and 1 is thiazides, telmisartan, losartan and the thiazides. So here thiazide is explaining the hypokalemia at initial presentation, and if we see according to definition, patient has a hypertension, hypokalemia, although hypokalemia is due to the thiazides. Second patient has had a adrenal incidentaloma, and third is patient has a fluctuating severe hypertension. So here also we are into query that it is primary hypertension or it is a pathological endocrine cause of the hypertension, because all category was not fitting into the particular cause. So if I summarize this case, then this patient has a 57-year-old lady presented with the adrenal incidentaloma with the type 2 diabetes, with a normal urinary metanephrine and non-metanephrine level, with normal serum cortisol. There was no any sign of the virilization with the hypokalemia at the initial presentation. So clubbing all things into the one slide, that we left with the 2DD, that it could be the still type 2 diabetes with the primary hypertension with the benign adenoma. Secondly, if it is unilateral adrenocortical mass causing the hypertension. So this DD was in our mind. So before that, I want to highlight some investigation. Here we have done sodium and potassium, which was there was in the December 2019 and September 2020. Before presentation to our clinic, there was a hyponatremia and hypokalemia, and patient was on thiazide, so it was explaining. And after a presentation to our clinic, all the sodium and potassium was normal. So, and I want to highlight about the thyroid function test. It was a normal, so ruling out thyrotoxicosis and other endocrine abnormality. So now coming again to our question that how to approach for the incidentaloma. So if it is size is less than 4 centimeter, and if it is not any malignant features, and preliminary function test is normal, then we have to do repeat screening after 1 year. So if it is size is increasing, then we have to do functional screening, and if it is functional, then we have to remove. So what is the history here? At the initial presentation 2019, the CT scan was showing the lesion around 20 multiply 14 multiply 18 mm in size, and after 2 years, this lesion has increased in size, which was 20. 24, 12, and 20 mm.
Because we talk increases more than 1 centimeter, as you mentioned. So this is similar in that perspective. Volume is similar.
But again, patient had a hypertension and was not controlling. So we gone for the further investigation, where plasma renin level was low. 0.1 picogram per ml. Plasma aldosterone concentration was high, 15 picogram per ml. And if we see the PAC to PRA ratio, then it is more than 150. So if you
differentiate this from the Dhwani case that you presented, that case had a very high aldosterone, 95. That is why the hypertension was much more severe. This is what you need to understand. That a small tumor may not be able to produce that much. If the whole adrenal produces, the level will be very high. But at this level also renin is 0. So that renin of 9 is huge for that particular perspective.
And what happens also is that because of the increased renin and aldosterone, there will be further vasoconstriction, the stenosis level accentuates further. And
worsening on that. And if you have a primary hyperaldosteronism with same level of blood pressure as compared to other causes of hypertension, you will have much more renal injury because of renal.
Yes,
the renal and cardiac outcome will be worse for the similar level of essential hypertension. That is a direct mechanism of aldosterone in that perspective.
Yeah. So here, as we are seeing that PAC and PRA ratio was sky high, which was more than 140. So here, if we see the low renin and normal high aldosterone, then we have to do CT scan. But actually, this patient presented with the CT scan at the beginning, at the initial presentation. So how to do interpretation at this stage? So we have the, if we have the increased PAC and PRA ratio, if it is less than 10, then all the renal causes is come into the picture, like renovascular hypertension, diuretic use, renin producing tumor. If it is ratio is more than 20, then we left with the 1DD, which is a primary hyperaldosteronism. If it is all are suppressed, then DOC or DOC producing tumor can cause this kind of picture. So this is the interpretation, and ratio is more than 20. So we left with the diagnosis of primary hyperaldosteronism. So here we advise for the surgery, and biopsy of the left adrenal was suggestive of there was a sign suggestive of the adrenal adenoma, so which was favoring our clinical picture. And by the follow-up, there was a normal cortisol level, a normal sodium and potassium level. And here, after follow-up, medication history was important. Previously, patient was on 2 to 3 drug of the medication, and aldosterone dosage was 50 milligram at the initial level. After the surgery, it became 1/4, around 12.5 milligrams. So it was significantly reduced the level of
the drug of choice in this patient if they are not planning surgery.
Yeah. So, sir, we have to give mineralocorticoid receptor blocker.
So,
and
aldactone or eplerenone, those will be the drug of choice. So, I think this is another very. You can all go and have a look at our website and explore our courses and the mobile application.